Good afternoon, everybody. On behalf of the Patient Safety Authority, I would like to welcome you to our webinar, the PSA Introduction to a CANDOR Collaboration for Pennsylvania Healthcare Facilities. My name is Michelle, and I will be your moderator for this program. A copy of today's slides are available. There is a link in the chat box on the right-hand side of your screen. If you don't see it there, you can click on the little bubble at the bottom right that says chat to pull it up. Feel free to open those slides and save them for your reference. The webinar today is being recorded. It will be available on our YouTube channel, hopefully in the next couple of weeks. We also welcome any comments or questions that you have during the course of the presentation. Please feel free, as you think of things, to type them into either the Q&A box or the chat box on the right-hand side of your screen. And we will answer those questions at the end as much as we can. I'd like to introduce our speaker for the webinar, Dr. Seth Cravat. He is the Senior Medical Director and Assistant Vice President at MedStar's National Center for Human Factors in Healthcare. He's also an Assistant Professor of Clinical Medicine at Georgetown University and an attending physician of palliative medicine at MedStar Georgetown University Hospital. Dr. Cravat is board certified in both internal medicine and hospice and palliative medicine. As a small disclaimer, he is not a risk manager, so he asked me to mention that, so you'll be a little gentle with him when we get to the Q&A portion on those types of questions. Seth, I now turn the program over to you.
Thank you so much, Michelle, and for the disclaimer. So I'm not a risk manager. I've worked closely with risk managers and our vice president of risk at MedStar for years. I'm really approaching this from the patient perspective, from a clinical perspective, and from a safety operations perspective. Today, we're going to talk about CANDOR, and we're going to start with a video, which is about 6 minutes long. It's a worthwhile video. A friend of mine, Jack Gentry, who was and is a MedStar patient. Please note that when you're watching the video, because of the technicalities of it, if we were in person, the audio would match perfectly with the video. It doesn't always match perfectly on this, but it matches close enough. So why don't we start the video and we'll talk a little bit about it afterwards.
In the summer of 2013, I began to experience a shooting pain in my right arm. I was having a difficult time holding a golf glove. I was losing the strength in my right hand. I went and had an appointment with my internist, who recommended therapy, and it really didn't have the effect that I wanted. Dr. Torlani recommended surgery. Things didn't go as planned. The 2.5-hour surgery took about 5 hours.
I've been practicing medicine, practicing orthopedic spine surgery for 13 years. So when I was doing my training, we were taught, maybe not too different than the airline industry, if there is something that's not typical happening in the operating room, first pause, and then second, call a trusted colleague and tell them about what you're experiencing and tell them what your plan is to get out of whatever the challenge is that you're in. Then mention it and talk to the family about it real time so that everybody is in the loop.
And I was thinking, oh, he's finished. He just wants to tell me that they're done and he's moving on and, you know, he'll be out shortly. And instead it turned out that he said things weren't going very well. Dr. Tortolani explained to me what was happening. He gave me 2 options, that he could either abort the surgery or he could continue with his new plan. and he wanted my permission to continue, and I said yes. I know it was very difficult for him, and I was very thankful that he did come out and talk to me, but I could tell for him it was very hard because he had known Jack for a while.
When I woke up in the recovery room that evening, I learned that I was paralyzed from the neck down. I had always been a fighter, and I told him, I said, let's get the show on the road. Let's figure out what we're going to do and get it started.
The difficulty that I have had with this gets to just trying to internalize something that was really tough, but their family has made it so much easier for me. And how dedicated they have been to his recovery has made it so much easier. And the fact that they did not push me away as their doctor has made it incredibly better in terms of maintaining a relationship.
You went way beyond apologizing, way beyond saying that he was sorry.
I mentioned it to our administration to let them know about this incident, just to make sure that we were doing everything we possibly could to support them. And they just brought it to a whole nother level of support for their family.
I don't remember exactly when I got the call from the risk manager who was on site at the local hospital. But when he called me, the question was, how do we deal with this? What should we do? When you work in an organization where the directive is to do the right thing, the answers are really easy. Tell them basically anything they need is what we're here to give them. We have to support them.
I was shocked personally that the hospital did say something happened on our watch. We want to be responsible for it, and we want to help you in any way we can.
Don't worry about it. We'll take care of it. And they did.
The first week Jack was in the hospital, we were supposed to be transferred to Good Sam Rehab, and we found out that our insurance was not going to pay for acute rehab. And immediately the discharge planner told us that MedStar had decided that they were going to pick up the tab for that, not to worry about it, that we were going to transfer him and get him the help he needed.
I went in the hospital as a patient, and then I became a victim. And that's not right. As a victim, the early intervention allows the victim/patient to get on with their life a little quicker.
If we're there in the very beginning, we can make sure they have home health aid. They have somebody in the house to take care of them. They have attendants if they need to, somebody to take care of their needs. That all can be done in the very beginning. In the old traditional way, I'm just looking at picking up the pieces after everything has been broken. In the new way, we're looking at taking those pieces and making sure they're melded together to get the patient the best outcome possible.
It's really made it much easier for me to just keep doing what I do and what I love to do.
MedStar did it all. They did emotional support, they did physical support, and they did monetary support. I think all of those things together are what's going to make it a success.
It was one less thing I had to worry about. It allowed me to concentrate on getting better. That just made life a lot easier for me.
So Jack is an incredible human being, as is his wife, Teresa. I spent a bunch of time with them. Despite him having sustained an injury at MedStar, I've done talks with him, and he works closely with our risk department and our quality and safety department now to help improve care for future patients. He doesn't talk about it in this video, though I've seen him talk about it elsewhere when he does his own talks. You know, Jack was on the Baltimore police force for, I believe, about 40 years. He was part of the SWAT team. He was very active outside. He talked about playing golf, but he actually, he was a hiker, he was a climber, he was a sailor, and he actually did something that I learned from him and Teresa. It was called spelunking, going down in caves. And so this was really a devastating injury for him. He's an exceptional person at baseline, so it helped in this case. And we learned so much from working with him. And I'm going to try to share some of that with you today in bits and pieces, just kind of an overview of this new and different approach to what we do when something goes wrong. So I'm going to start by showing, you can see this slide of, this is the Asiana 777 that crashed in San Francisco in, I believe it was the summer of 2013. The reason why I show this, this plane crash is twofold. One is because our patients and families have told us for years, they've told me personally that when something goes terribly wrong in their care, it feels to them like a plane crash feels. There's an urgency around it. They want something done. They want to understand what happened. They want people to respond quickly. And the second reason why I show this is because you can see on the back of some of these people's jackets, it says NTSB. And most of you, all of you know the NTSB investigates transportation crashes. The NTSB in this picture is not arriving at the crash site a month later, weeks later, several months later. They arrive immediately. And when we learn about what we call serious unanticipated outcomes in MedStar, the expectation has been sent that we respond immediately, similar to what the NTSB does. And I'll go through this now, though there are multiple reasons why this sense of urgency is really important. So the NTSB has a GO team, and we can read it here at the core of their GO team. The core of their investigations is this GO team, which is simple and effective. Begin the investigation of a major accident, and you can substitute unanticipated outcome in healthcare at the accident scene as quickly as possible, assembling the broad spectrum of technical expertise that is needed to solve complex transportation safety problems. So we apply, and CANDOR applies that same concept to our healthcare GO team, which is a team of trained individuals who respond to patient harm events and coach others on how to respond in a timely, empathetic, consistent, patient-centered, and effective way. So really important that we have a team of people who are ready to respond when something goes wrong. There's 4 components here of the healthcare GO team, and they don't necessarily have to go in sequential order. They all sometimes can occur at the same time. There's disclosure and communication with patients and families. That's really about the empathy and understanding what's important to them. There's care for the caregiver. I'm going to say this now, and I'll say it again later, that in my years of safety and reviewing safety events, I've yet to meet anyone who intended in healthcare to come and harm somebody. Everybody really was coming to work intending to make things better for the patients we serve. Event review is what we call it in CANDOR and at MedStar, formerly known as RCA, root cause analysis. We don't call it that. We'll talk a little bit about more why. There's early intervention, which really goes along with the resolution part. That's really what we rely on our risk department partners for. And then there's a resolution. How do you actually close out an event with the understanding that we always say that we don't close out an event until the patient and family tell us it's closed out. It's not based upon our metrics. It's based upon when it feels like it's done for them. So I'm going to start first about talking about disclosure and communication with patients and families, knowing that we call it disclosure and communication. And the reason why is because disclosure should never be a one-time event. It's not something you tell people, you go disclose to the family or the patient and then you're done. Disclosure is an ongoing event where we're consistently sharing information and messages as we learn new things and based upon what the patient and family need. So here we like to put down a definition of what is full disclosure. So disclosure refers to communication. It doesn't say one-time communication here, but communication between a healthcare professional and a patient, and a healthcare professional can be someone who is non-clinical also, and a patient, family members, or the patient's proxy that acknowledges the occurrence of an error, if there was an error actually involved in what happened. So sometimes we have unanticipated outcomes where there wasn't an error, and we share that with the patient and the family. Discusses what happened, so we talk about sharing what you know, don't share what you don't know, and we'll have hopefully future trainings on how to do an optimal disclosure. And 3, describes the link between the error and the outcomes in a manner that is meaningful to the patient, so that if there was an error or if there was an error, the patient and the family are able to understand and make that connection of how things happened. That's very important to patients and families. So why do we do this? And this is really, I'd say, first of all, it's the right thing to do. just remember that always, it's the right thing to do. It's one of the places in life where it's in some ways can be very much a win-win situation where you're doing the right thing and it works out both for the patient and your organization. And now let's work through some of these bullets. That patients have a right to know the details associated with unexpected outcomes. So a patient wants to know, how will this affect my health in the now and in the future? It gives us a window or an opportunity for compassionate, professional, patient-centered care. So it's what we all went into healthcare for, as far as I know, and it's just another opportunity. And the third part is it allows us for increased organizational learning, sometimes learning actually from our patients and families what happened. And this learning can translate into safer systems-based practices and possible repair of this patient-caregiver health systems trust. So if patients and families actually understand what happened, understand the complexities of healthcare delivery, and see that we are learning with them and on our own, they actually may walk away feeling more trustful of the system than less. So as I said, it's the right thing to do. It's part of the AMA Code of Ethics. We do not withhold information from patients. And so it says here, truthful and open communication between physician and patient is essential for trust.
This is Zoe. I'm not sure if you can jump in or not.
Yeah, absolutely. I'll jump in until staff gets back. On this slide, we have a continuation of what Seth is saying. Disclosing is the right thing to do, morally and ethically. And this is also part of the AMA Code of Ethics. It is our responsibility to openly communicate between the physician and patient and create a truthful and trusting relationship.
So some people worry that if we disclose and we give information to patients, this will give them the opportunity to sue us. But when we talk to patients and families about why they sue, here's what we found out. So number one, and again, this was found from an older study, but number one, patients want adequate information on how the injury happened and why. And I will tell you from years of doing this, and again, I see there are a bunch of patient safety officers on this and also people from the legal field. This is what patients told us repeatedly. We sued because the healthcare organization took a deny and defend position. We couldn't get the information we wanted, and so suing was the only way we could do this. So we went and we got a lawyer. Number two, an explanation of how future patients will be prevented from similar harm. I've been on calls, I've been in person with patients and families who said to me, and as I explore what's important to them, they say, I don't want this to happen to somebody else. And even when I don't ask, often patients and families will offer this as a reason, something that's really important to them. If they don't know that we're doing that, they are more likely to go get a lawyer. Sometimes they need financial or other support in the immediate aftermath of the harm event, and we're going to talk shortly about early intervention. Sometimes they need long-term compensation for their actual losses, and sometimes really we do actually probably owe them that. And then they want an acknowledgement of responsibility for the error, so that if we made an error, that we say we actually made an error. It's important in relationships one-on-one, and it's important in relationships with our patients and our families. So doing full disclosure, giving patients and families the information that they want and need, addresses the primary reasons why the patients sue. So apology statutes, I'm not an expert on these. I'm not going to go into these in detail. The point of this slide is really to tell you that when we speak to plaintiffs' lawyers, and our Vice President of Risk has some good relationships actually with the plaintiff lawyers, they don't want apology statutes because they know that as soon as we allow healthcare systems to easily apologize and not worry that they're going to get sued for it, plaintiffs' lawyers will start losing business. And this is because people go to plaintiffs' lawyers. This is a very prominent plaintiff lawyer in the Washington-Baltimore region who I think has won hundreds of millions of dollars in cases. He says to us over and over, people come to him not because of the injury, they come because they're angry. And they get angry because we're not honest with them, because we don't provide them with information, and because we don't follow up with them and make it easier for them after they've had a bad event. Big fear that disclosure will lead to increased legal expenses. This is the example from the University of Michigan that implemented a full disclosure program. And I don't know how many of you know Rick Boothman. I've heard of him. He speaks about this brilliantly. They implemented this program of full disclosure medical errors, also with compensation. So offering up compensation, not waiting for people to sue you to get compensation. And they actually had an overall lowering of their liability costs. So really important. And we had I'll talk about this at the end. We had a very similar response at MedStar. Let me talk quickly about what early intervention is. So early intervention is what happens. So somebody reports a bad event to you. We don't know if we did something wrong or not. We put a system in place at MedStar for people to report these things often and frequently. Initially, we had people only reported events to the risk department when they knew that they did something wrong and it caused a bad injury. And we then encourage people to report any what we call serious unanticipated outcome immediately. And before long, we were getting hundreds of these every year. Not because we had a whole bunch of serious safety events. It's because things sometimes go wrong in healthcare, or our outcomes aren't as intended, as we all know. Doesn't mean we did anything wrong, but how we respond to those moments is really important to patients and families. So if you can get somebody or get your system to report things to you early, the people with a few extra dollars can then provide support to patients and families. Things like accommodations. If a patient, we have patients come to some of our tertiary care centers, and they come from far away. Their families expect them to be there for a surgery and be there for a day and take them home. But let's say something goes wrong. All of a sudden, they need to stay. The family may not have a lot of money. The places to stay may cost a lot of money. We can immediately offer to cover their accommodations. People may need to travel from elsewhere. We can offer to cover those. We can give them food. We don't want somebody who's been involved in a bad event in one of our hospitals to have to start worrying about paying for parking. And again, most of these things are very small dollar amounts in comparison to how much we would have to pay out in a big lawsuit. So on top of that, again, it feels like it's the right thing to do. They do this in other industries. It's called service recovery, or it's treating people right. But consider that as, if you can get people to report things early, you can start supporting your patients and families immediately. We've done everything at MedStar to supporting people's wages. If the person who's injured is the breadwinner, people worry about losing their homes. They worry about not being able to pay for their cars. And then there's psychosocial support. What people need in early intervention, it aligns with what we discussed around disclosure, is variable. And a lot of what we need to do is speak to patients and families, understand what they need, and then provide that. Early intervention, so we start with early intervention at MedStar. We provide them, we have our open discussions around disclosure and communication. We find out what they need. Sometimes it's information, sometimes it's information, a place to stay. We put all those things together. And then what we do is we continue those discussions. So sometimes patients and families want to have them, sometimes they don't. We make sure that the door is open for them, that we have a plan for follow-up. They have the right numbers for the people to contact if they have any questions. And this sets up a much nicer relationship with our patients and families, turning down the heat and allowing us to have real and good discussions about how do we resolve this in the end. So let's talk a little bit about care for the caregiver. So what is care for the caregiver? We call it care for the caregiver at MedStar. Some people refer to programs as second victim programs.
Looks like we lost Seth again, so I'm happy to jump in. So what Seth was saying is we have a program called Care for the Caregiver, and some people call this a second victim. Healthcare givers are the second victim to a serious unanticipated event at a hospital. But we choose to use the term care for the caregiver because the second victim terminology does sometimes rub patient advocates the wrong way. And so we like to use this term. And what care for the caregiver is, it's any kind of support and empathy that we can provide people who have been involved in serious events. Any of you who are in the medical field or are clinicians yourself will probably experience some sort of serious unanticipated event in your career. And these events are often very harrowing for people. You know, as Seth was saying in the beginning of this presentation, people come to work to try and do a good job and to help people and do their best. And when that doesn't happen, it can be devastating.
So I know Zoe was talking about the care for the caregiver. I was talking a little bit about second victim, and what we've heard from our patients and families is that they prefer us not to use that term, so we stick with care for the caregiver. I assume Zoe covered a little bit of the tiers. Tier 1 is really about someone just showing you empathy, so getting this empathy out into your organization so the people in your organization know that taking care of people after serious unanticipated outcomes is exceptionally important. The next level is training peer supporters, so people have a little more information about how do you provide additional services to your colleagues, actually giving them tools, and a lot of times it's people in your organization who volunteer to do this. So reaching out and saying, listen, we have this Care for the Caregiver program, we have training, and we'd like to have volunteers. We've had no problem ever getting people to volunteer for this. I've been in many rooms with healthcare people where they, when we talk about care for the caregiver and what they've been through, that people start to cry. So this is really important. And the third level is there are times when a serious unanticipated outcome can be so devastating to a healthcare provider or anyone involved in the team that they need a professional help. At MedStar, we have an employee assistance programs. A lot of other healthcare organizations have something similar, but ensuring that if they need a psychologist, a social worker, somebody else, that you have a referral network to which they can go. Really, really important. So this is a quote from Albert Wu, who studies this extensively at Johns Hopkins, a physician there. And this is really important. Physicians and healthcare workers are just human. I will read in the news about healthcare workers making mistakes, and sometimes there's kind of a blaming tone without a true understanding that people make mistakes, they make them all the time, and healthcare workers are still just human and they will make mistakes. And he says, strangely, there's no place for mistakes in modern medicine. Society is trusting physicians, and I will say broaden this to say not just physicians, but the healthcare team, with the burden of understanding and dealing with illness. Although it is often said that doctors are only human, technological wonders, the apparent precision of laboratory tests, and innovations that present tangible images of illness have in fact created an expectation of perfection. And again, I'm sure for all of us on the phone that we all know that this is just not possible. So these visuals really are focused on a lot on COVID and how COVID has created this environment of burnout. But really, there's burnout everywhere through healthcare. Even before COVID, this has only made it worse. And you can click through some of these. And when you think about this, it's become even more important how we have to take care of our colleagues, our workers, the people that report to us, the people we report to, that healthcare is a community. And for too long, we've kind of been this tough, I'm going to tough it out kind of approach. We've had that kind of approach. And we really need each other now more than ever. So a Care for the Caregiver program in response to these bad outcomes is really important. Unfortunately, the suicide rates, when we look them up, the most recent rates for physicians and nurses do not look good compared to the general population. We actually had an older slide in here before, and we were hoping that when we looked them up that the rates would actually have gotten better, and they have not. So when we look at this, a female physician is 130% more likely to commit suicide than a similar person in the general population. A male physician, 40%, a female nurse, 58%, and a male nurse, 41%. And this really talks about, again, the burden we have just from our basic regular jobs. And then you think on top of that, we add a medical error or a bad outcome that we didn't expect, and it only adds to that burden more. And so, again, I'm going to keep saying this, caring for each other during these times is exceptionally important. Some of you may have heard the story of Kimberly Hyatt. She was a nurse at Seattle Children's Hospital. She had worked there for approximately 20 years. She was a good nurse, and she overdosed this baby, Kaya, with 10 times too much calcium chloride. She went home that night and thought, and worried that she had done it and called in, but it was too late. The response was not to take care of Kimberly Hyatt, but at the time was to punish her. She was not supported, my understanding that she was sanctioned by the Board of Nursing. And Kimberly, who was a mother of 2 younger children and had a partner, committed suicide 7 months after this. This is exactly the thing that we do not want to happen after a medical error. So we want to protect our healthcare workers as much as we can. We're doing it in COVID with PPE. We do it with I've been giving vaccines. We have special needles that retract automatically so we don't have needle sticks. And we also need to protect their mental health and their psychological health. So by doing so, we can do things that are important operationally and also from a human perspective. So reducing burnout, preventing turnover, keeping individuals in the healthcare profession longer, those are all things operationally. They're very important to us in healthcare. If we can have people enjoy their jobs more and not leave the profession, we maintain their organizational knowledge, we maintain their professional knowledge within our organization, and we actually save money. On top of that, we are hopefully going to reduce depression, suicide, and create an environment where we all want to come to work and can enjoy what we do and share that enjoyment with our patients and our families. Now I'm going to talk about how do we learn from these events. And I'm going to give an overview. So I talked earlier that we do not call it at MedStar a root cause analysis anymore, and I'll give at least 2 reasons for that. One is that what we have found, we work in the human factors engineering group and look at safety science, that there's rarely, from a safety science perspective, one root cause for any event. There are often multiple contributing or causal factors. If our goal is to get to one root cause, we may miss the opportunity to understand the complexity of the care that was being given in our very complex healthcare environments. The other reason why we avoid this is because when we looked at root cause analysis at healthcare organizations, a lot of times people had a negative response to it, and that was because it was they thought an RCA was a meeting that occurred several weeks to several months after an event happened, where we put everybody in a room, we tried to figure out what happened, and occasionally blamed people. And that's not what we actually do at MedStar, and it's different from the CANDOR approach, which we actually helped write and design. So when you look at the response, the event review process that CANDOR espouses, there's an immediate response, which we've been talking about. So we need people to report these serious unanticipated outcomes early and frequently so that we can respond. We can respond by reaching out to our patients and families early and communicating with them, and also learning from what happened, learning their view of what happened. We can provide care for the caregiver, for our staff. And then we can gather time-sensitive information. So things get lost if we don't have an immediate response when we think back to the NTSB. So they get there early because we don't want to lose critical pieces of information that might be lost over time. So things like EKG strips, telemetry strips that might get thrown in the garbage. We may lose an opportunity to look at the environment of the unit at the time. So how busy is it? Was there any equipment missing? We may lose the opportunity to look at a medication bag that was involved in the event. So the immediate response is very important. We say, go to the floor, figure out what you can figure out early. The next step is really the in-depth review, and the in-depth review should be conducted by clinical people combined with people who understand safety. So sometimes, oftentimes, that is one person, but if it's not one person, combining a clinical person who can do a deep dive into a medical record with a safety person who can understand the different contributing factors and with a socio-technical viewpoint is really important. The in-depth review consists of often a really good deep dive into the electronic medical record or just your medical record period, and interviews. Interviews, we'll talk about this in a future webinar, really, really important to hear from people about their work. By doing this, plus looking at equipment, looking at environments, safety professionals often find that these contributing or causal factors start bubbling to the top. Every time I've done one of these reviews, that's always what happens. The things that contribute to this event start bubbling to the top. The safety professionals then put that information together and package it for what we call the confirmation of consensus meeting. That's when you actually gather people together. It's not really an exploratory meeting. It's a meeting where we bring what we found to a group of people who actually do the work. So it could be, this is where you can put physicians, nurses, the people who deliver the food, someone from pharmacy, someone from lab in one room. And the safety professionals say, this is everything we found out. This is what we think contributed to it. Can you please confirm that we got this right, correct some of these things, and let's all get to come to consensus on what happened here to the best of our ability. Once that is confirmed, the teams can start thinking about solutions, and the solutions meeting can happen combined with the confirmation consensus meeting sometimes, and sometimes it requires a different meeting. And then, of course, there's follow-up to actually make sure that things occurred. So I put this slide up. This is a mantra of the Human Factors Engineering Department at MedStar Health about minding the gap between, if you click twice, work as imagined versus work as performed. If you can figure this out, you are going to figure out what the contributing factors were in any event. So work as imagined is what people imagine the work to be. So based upon policies, I put out a procedure, I created a training as a manager. I imagine that that's how the work is happening. Work as imagined is often slightly or sometimes very much different from work as performed. So that's how the work is actually being done by the frontline people. Your goal is to make sure that you do not sit in the work as imagined space. You want to get the work as the work as performed space. And this is, if you could take one thing away about event review, this may be the most important one. So what is supposed to happen can be work as imagined. So if this were working as designed, as best as we could design it, and everyone's following the rules, that's what's supposed to happen. We want to hear from the people who actually do the work. Tell me and show me what usually happens. If you get them to trust you, they will show you what they normally do. We've all heard about workarounds in healthcare. We've seen them. We've probably done them. And if we understand what usually happens and what actually happened this time, which may be what's different from what usually happens, and we can bridge that gap between those things and what is supposed to happen, we can actually start to think about fixing problems. If we don't get to that what usually happens or that work is performed or what actually happened this time, the solutions we design might be very different from what is needed. So this is a famous human factor slide. So we put somebody in front of a very complex machine and say, good luck. This is similar to healthcare. I can say that as a physician. I've been thrown into many environments where I feel like I'm getting the good luck sign and I have to figure it out on my own. We say, although we cannot change the human condition, we can change the conditions under which humans work. So we're not going to change that humans are fallible, but we can redesign systems to make it easier for us to do the right thing and more difficult to do the wrong thing. So I'm going to talk quickly about effective and sustainable solutions. So once we figure out that minding that gap and understanding what really contributes to these events, we can design solutions. So we want effective solutions that actually address the problem, and they need to be sustainable over the long term. And I'll show you just 3 simple examples. Railroad crossing, problem is that cars or people have gotten hit on railroad crossing. That's a safety event. So one thing we can do is we can put up signs, which we do that. If you go to any nurse's station in a hospital, you'll see lots of signs telling people what to do to try, hopefully make us safer. The signs are minimally effective, but they can create a little bit of risk reduction in the short term. So a better solution is actually to put down a gate, right? So this is a clear signal. It makes it harder for me to go across those tracks. But as we know, somebody can still walk around the track. Somebody can drive around, walk around the gate, drive around the gate, even drive through the gate. So it's not mistake-proofed yet, but it's a better solution. And then the final one is, you know, when we put a bridge over the road, it makes it nearly impossible for the train to hit a car, and that's a long-term solution that is much more effective. And we can apply similar principles when we design solutions in healthcare. And if I had to put all this together now, we talked about the University of Michigan experience. We had a very similar experience to date at MedStar when I was in charge of safety for the system from 2013. I was in that position until end of 2019, but through 2017, we saved about $100 million with this approach in place. There are other things that contributed to it. The most important thing, though, is that despite us disclosing, or maybe because we were disclosing and communicating and providing early intervention and doing care for the caregiver and doing these systems-based event reviews, our costs went down significantly. And it actually, as I said earlier, was a win-win situation. It was the right thing to do for our patients, and it was the right thing to do for our organization. And I think that's my last slide. And now I'm going to turn it back over to Michelle. And thank you for having me today.
Beth, I'm going to talk briefly about what we have planned for our collaborative project. So Seth mentioned, you know, really the key component of CANDOR. And a lot of these things are things I know many of you are familiar with. Response and disclosure, care for the caregiver, that event investigation piece, resolution, and then also organizational learning and sustainability is really important with this. You know, how do we learn from those events and how do we sustain our gains? So as we go through each of these component modules with the project, the facilities that sign up will do some collaborative webinars. Seth and his team, as our experts, will share with us their knowledge and the lessons learned from their implementation of this. And then there's also things that we can do for the facilities and organizations that are very specific to their needs. We recognize that, you know, while disclosure is part of MCARE and people are doing notification letters, you know, some facilities may have a much more robust system than maybe others do. And maybe those facilities that don't have as robust of a system in disclosure have really robust care for the caregiver programs. So what each facility is going to need is going to be really different, and we know that. This isn't a cookie cutter type of project. It really is geared towards meeting your needs and offering you the support that you need to get through it. Just to give you an idea of our timeline, obviously February, this is the introduction. This is the time for you to familiarize yourself with CANDOR, decide if you want to go all in. We'll have a facility self-assessment and a letter of intent that will be due in March. The letter of intent is due on March 26th, and then the self-assessment submission will be March 31st is the due date for that. We'll work through those 5 component modules, the webinars, the facility education and consultation. Each of those will be about 3-month time periods, so there may be some times where it's not as much work for your organization and some where it is. That takes us through June of next year, and we'll wrap up July with our wrap up and then launch cohort 2. So we know that not everyone is able to take on something like this right this second. And so we're looking at doing that second cohort of facilities who can't jump in at this point, but really want to do this work in the future. That gives you a date to kind of target. A couple key things before you decide to sign on the dotted line. It's going to be important that you have a multidisciplinary team in your facility. None of these things can be done by one person. It's really a change in culture. And, you know, changing culture and changing how you do things in a facility requires that buy-in and that leadership support. It requires people from across the organization to come together and work towards it. So having that leadership support and that multidisciplinary involvement is going to be very important. It is an 18-month commitment to do. You know, if you want to work ahead, I suppose you could. And like I said, it's not 18 months of solid work. It's really going to be very dependent upon what your facility needs. And we'll support you and we can offer you that expertise, but it's really going to be tailored work to what the facility needs. And ultimately, there's going to be a lot of benefits to not just the patients and their families, but the healthcare team and the facility as well. We aren't asking for any data to be submitted other than the facility self-assessments, which are kind of like checklists to go through the components that you have in place and how far implemented they are. But we're not asking for any other data submission or any other extra work as part of the collaborative process. If you are interested, please feel free to send me an email, michbell@pa.gov is my email address. If you have any questions, if you want to, if you're interested, if you want to indicate that you're interested for cohort 2. If you let me know you're interested, I'll send you a copy of that letter of intent that you can review then with your leadership team. You'll return that back to me. And then you can start to figure out who you want involved in that implementation team. Part of the letter of intent does identify the project lead that will be our main contact person for the work. And I'll send you that self-assessment so that you can start going over that with that team that you pulled together. With that, I think we're at question and answer time. So if you have questions, again, the chat box and the Q&A box on the right-hand side of your screen, you can use either of those. Feel free to enter your questions into those boxes, and we'll get through as many as we can. Seth, I do have a question here for you that I think would be a great one. What discretion does the frontline staff have for reimbursing items, especially larger items like lost wages, supporting rehab, or long-term care?
Good. Yeah, that one I can answer. So this is the importance of reporting early, really important, and also ensuring that safety and risk, if they're separate departments, are very, very closely aligned. So we don't have the frontline staff promise anything, and it's part of our communication training, actually, that we don't want them promising any sort of reimbursement. What they can say is something like, you know, we have a team of people who can try to figure out what's important to you, what you need, and we will ensure that we connect you with those people. So we really need the people who are in charge of one, in charge of the dollars, but also who can make those decisions. So really important that they're connected to risk if those are the people who are going to make the decisions. And then Michelle talked a little bit about the importance of having leadership on board. We have leadership throughout all our organization now who know that this is what we do. And so they've empowered, when we say frontline, they've empowered our risk managers to do a lot in this space. I don't want a frontline nurse or doctor promising this stuff, but if we're talking about frontline risk managers, absolutely, they should be empowered to at least start those discussions and start offering what may be possible.
Okay. I do have a question about getting a copy of the slides for today, and Shelley is putting the link to that in the chat box for you. So if you want a copy of those slides. And then also, Shelley, if you could put my email address and those due dates in the chat box as well, because I know that those are reference things that people are going to want to write down and not miss. I do have another question here, and I think, Seth, this is another one for you. Is there some type of huddle or touch point before that team goes in to talk to the patient or family? And then do you involve safety, risk, and the clinical and claims people in those early discussions before the family even is notified?
So this is actually a precursor to what we do when we talk about disclosure and communication. So absolutely, it's one of the things we recommend. It's really important. It's preparation, preparation, preparation. So yes, we prepare. We definitely have a huddle. We huddle to make sure that we're all on the same page about what we know, what roles people will play, who's going to speak, who's not going to speak. It's important we talk about people being able to check their emotions at the door to make sure people are okay. So if somebody feels extra sensitive about something or is struggling, maybe they shouldn't be the people to go in. And so, yes, always really important to prep before you go in. That's one, and we do recommend huddles. And as far as safety, risk, clinical claims involved in this pre-discussion, yes. So every organization is different, so you need to decide how early each one of those people need to be involved. Any one of those people could absolutely be involved in the discussion. Sometimes those are the people having the discussion. What I would be really careful to caution you against when you think about this is, you may not be able to have every piece of information when you go in, and we shouldn't be delaying these discussions for hours or days or weeks because we haven't conferred with everybody. If we start doing that, we lose this opportunity to get to the patients and the families when they're most in need. So really, really important to say, how do we act quickly? How do we get as much information as we can? How do we include as many people who need to be included as we can, but without delaying this discussion that needs to happen? And it needs to happen immediately or as quickly as possible.
Thank you.
You're welcome.
Yeah, we have another question. We've talked a lot of different terms have kind of gotten thrown out in the conversation today, and someone's asking about differentiating between the terms of harm, unexpected outcome, error, negligence. Like, what are the trigger points for a CANDOR event, and is it any of those things or all of those things? The example they give is, just because a patient has a cardiac arrest does not mean that there was negligence or error, but there certainly was harm, and is that, unexpected or not is obviously contingent upon a lot of things. So what triggers that, and how are those differentiated within CANDOR?
Yep, and I'd say that, we talked about this a lot as we looked at this process, and really, we just started speaking about serious unanticipated outcomes. So there was an outcome, and the outcome often is harm. So the patient had a cardiac arrest, worst case scenario, but the patient had to go to a higher level of care because we gave them the wrong medication, or the patient had to come back for another visit because we missed something on an x-ray. Any one of these things are unanticipated outcomes. We didn't expect them to happen. And if it could be determined to be serious, and I think it's really important to know that serious from the patient's and family's perspective. Putting ourselves in the patient's and family's shoes, I've seen too often people say, well, I don't think this is serious. And I think, well, if this happened to me or my loved one, I'd feel it was serious. So anything unexpected, an unexpected outcome, and that's serious should trigger this. You don't want to be triggering a CANDOR event if we give the wrong medication to somebody and nothing happens to them. Do we want to review that? Absolutely. Would it help to communicate with the patient and family? Yes, and sooner is probably better, but it doesn't necessarily need the full-on CANDOR approach here. And there are variations on this. So, and part of that is you assessing this in your own organization. You need somebody to be able to do this. But I think the most important thing is for people to tell the decision maker about triggering the CANDOR event that your people in your organization know where to go and who to tell. And you tell them, I'd rather you tell me then hold it to yourself. And if you're wrong and we don't need a full candor approach, then we won't do it. But focusing on, is this an adverse event? Is it a serious safety event? Is it reportable? All those kind of things, just to have people put themselves in the patient's and family's perspective. We didn't expect this to happen, and someone needs to go talk to them and start working on some of these components.
Okay. We only have a couple minutes left. I have one more question before we wrap things up. Are your physicians employed and insured by the health system? If not, and there was a physician issue, how do you deal with that within CANDOR, and how do you handle finances in those situations?
Yep, that's a good question, something we've dealt with. So we have employed and non-employed physicians in our organization. It is way easier with our employed physicians on multiple levels because most of them are insured by us. That said, some are not insured by us because they may have a tail issue or something like that. And then we have all these other physicians who may not be employed by us who may be involved in an event. In those cases, so for MedStar, we're a big organization, we self-insure. We do our best to encourage private insurers to do what we do, knowing that it generally has a good outcome for our organization, for the patient, and generally from a risk perspective. There are times we cannot convince them to do that, and then we have to kind of figure it out on a case-by-case basis how we're going to do that. In the end, we're a large healthcare system that's focused on delivering the right care to our patients and their families and their loved ones. And so in the end, we would still disclose, we would still do an event review, and we would still provide some sort of early resolution, early intervention if we need be. So it's a really good question. It's something that we continue to work on in the industry. Our Vice President of Risk, Larry Smith, is very involved in negotiating and communicating and trying to develop standards with other insurers in healthcare.
Okay. Well, thank you so much, everyone, for your time and joining us today. This is going to wrap up our webinar for today. If you have questions or if you want to have more discussion or if you're interested, for sure, please feel free to email me, michbell@pa.gov. And for today, thanks again. Have a great afternoon.